so without further ado, I'll hand things over to Thomas.
Thanks, Brian. And thank you, Ronnie, and everyone for inviting us and putting this all together. Thanks to David Flannery, who's going to join me in this presentation. The idea about this session today is really to sort of bring you up to date on what we've been doing in the region, but also activities in other regions and nationally with respect to telegenetics. We've been working hard to make this productive, and I think we've had some successes, and we still have some to look forward to. But I'll just start with that and ask you for the next slide, please. So I'm going to talk to you about, what's the point of doing telegenetics, just very briefly. You probably have that in your head already, but just to explain it briefly, and then tell you a little bit about a survey that we did in 2007 about telegenetics, a national survey, and then we'll hone on down a little bit towards Region 3 activities and other activities at the national level or in other regions, and lessons learned. And then I'll pass it over to David Flannery from the Medical College of Georgia, who has a lot of experience with telegenetics in Georgia, and he's going to tell us very specifically about activities in Georgia. So next slide, please. So the point of telegenetics, why do we want to do this even more complicated way of seeing patients who are already complicated to us, is that it potentially solves some problems such as the tremendous inadequacy of the number of people providing genetic care to patients throughout the country. It's also a potential solution to distance barriers or geographical barriers, and I'll show you a couple of examples of that later. And the last 10 or so years, I think we've seen a dramatic improvement and, let's say, simplicity in using complicated technological systems for those of us who are not complicated technologists. And so we can use telemedicine now, even as we're doing today, streaming this lecture to various people around the region and even outside of the region. Next slide, please. So typical uses of telemedicine, which you may or may not be familiar with, have existed for a while. And so you can use a telemedicine system to have an outpatient interaction with a patient. This has been used a lot in various clinical fields, pediatrics, counseling, that sort of thing. It's also been used a lot with technological information such as imaging and radiology. So you can do an x-ray in one place, somebody else in another place can look at that x-ray through a connection and give an interpretation that's perfectly as good as if they were in the room with that x-ray. So that's sort of traditional stuff. You can also do inpatient consultations, assuming you have an adequate image of the patient that you're looking at, and assuming that the patient's problems are amenable to a non-touch kind of an intervention. But you can even have the person in the room with the patient do some of those things for you. Emergency rooms have done this as well to link them together. When one emergency room had, let's say, a particular specialty or ability that another emergency room didn't. And so there are lots of ways of doing intensive care medicine that way as well. Educational sessions, we're doing that now, and we've been doing that in the Southeast region for quite a while, streaming these sort of educational conferences to other folks who can't physically be in the room, and that's a really wonderful thing from my point of view. And then conferencing to do work. Ronnie and I use this system to collaborate on our regional collaborative efforts, and that has worked very effectively too. Next slide, please. 2 computers and 1 phone.
Exactly.
It's never complicated enough. So here we go. So I'm going to tell you a little bit quickly about the 2007 survey that we did on telegenetics to try to figure out, what's going on out there, what has been done, and what are people doing. So the National Coordinating Center, which is the body over all of the regional collaboratives, has a work group on telegenetics, and we developed this web-based survey which we sent out to over 1,000 people in various email lists that we could identify through the ASHG, the College of Medical Genetics, which is misspelled, sorry, various entities such as that. We define telegenetics as the use of technology that facilitates transfer of visual and or audio information over a distance to allow clinical services, conferencing, teaching, or research. And so this was a fairly broad definition, and we wanted to see what are people doing. So, next slide, please. So we asked these folks and got about 426 responses, which is not terrible for a survey. It's pretty standard, a 40-ish% response rate. Most of the folks were either genetic counselors, 144 of them, or physicians, 122 of them. And so, and then there was a whole big mix of other folks. Next slide, please. So these folks primarily came from academic medical settings, a university hospital, but then again from a number of other settings as well. Next slide. So when we asked, do you now use or have you in the past used telegenetics in any way to provide services, teaching, or learning experiences, 43% of the 434 that responded to the question said yes, they had or have done in the past. So that was an interesting number. We would never have guessed what that number is. Next slide. If not, would you see some form of telegenetic technology being useful to you in the future? And 77, almost 78% said yes, they would find it potentially useful to them in the future. So the next slide. So for those who had not been using telegenetics, why have you never used this system, we asked. And besides the commonest, well, it's not available to me, that's obvious. The two leading causes were cost. About 23% said they felt it was too expensive, and the other was an institutional barrier. So what those are, we don't actually know, but we could probably guess that they may have to do with IT or physical space limitations, that sort of thing. Next slide. So, of those that were using or had used it, their systems in 56% of the cases were part of an institutional system that they sort of piggybacked onto. So it wasn't just them that set it up, but rather part of a larger system. 25% had a regional, 23% had a state system, so there may be some overlap in those numbers as well. Interestingly, 44% did activities which crossed state lines, and even 16 crossed countries. So we're using this in foreign countries. And I know Bob Zori, who may or may not be able to join us on WebEx because he's in Italy at the moment. He's actually done some of that sort of work with his colleagues in Italy. Next slide. So what about financial support? 53% of the folks who had used this system in some fashion had been supported by grants. And those grants were most commonly federal or state, private, institutional, and contracts. 34% did clinical service and billed for those services. And I think that's a number I want you to hold in your head for a moment for the next slide. 34% billed for their services. Next slide. When asking how many of you used your system for clinical services, 65% said they used it for that service. So one of the most interesting things to me is that observation that only half of the people that used it for clinical services actually got billing or received fees for those services. And I think that that's a lesson to be learned. It's also an artifact because you can get good reimbursement through telegenetics, telemedicine services. You just have to sort of have a feeling for doing it. So what services did they do? They 67% used it for genetic counseling, follow-up evaluation. Initial evaluations were about half or so. Teaching, it's not exactly clinical service, but maybe it's teaching to patients and or to nurses, physicians, that sort of thing. And then a small percentage used it for that technological transfer thing that I was describing, using it as for ultrasounds, probably prenatals. Next slide. So in summary, this was just a first pass to give us some sense of what was going on. A lot of people had some experience with telegenetics or telecommunications, especially doing clinical medicine. And the reimbursement was perceived as a big barrier. So that's an important issue we'd have to address, I think, going forward. And then it seems as if a significant source of funds for these systems is soft money. And so gives you a little less confidence in committing to these systems when there may be a significant startup fee, lose your grant, now you're stuck with expensive equipment that you can't use. So there may be some significant psychological or barriers in other ways there. So that was our survey. Next slide, please. I did some research, and I'm sorry I don't have the reference here, but in fact, in telemedicine, there's good evidence that reimbursement is quite effective and is essentially as good as face-to-face if you use the right codes. And those codes exist. They're probably somewhat variable between states, but I haven't heard a lot of surprises. But we're still not using these codes very effectively to support these systems. We're still relying primarily on grant funding, and I think that that's because it costs more than just the reimbursement to actually do this service, and we'll talk a little bit more about that. Next slide. So I just want to describe to you briefly some of the better known successes or activities in the country in terms of telegenetics. Maine has a system that's been up and running for a while with variable success. The Northwest region, I'm going to leave the Georgia's story to David, who will tell that much better than I can. Florida has been doing telegenetics for a while, and I'll tell you a little bit about that. They have a publication in '06 about that. Arkansas has a very well-developed system that was set up about 8 or 10 years ago through the OB department, where they have one major center in Arkansas, and OB had the money to set up a big hub and spoke kind of a system. And everybody, or at least genetics, has piggybacked onto that in a very successful way, I think. And then I'll tell you about our experiences in the Southeast region. Next slide. So in Maine, they set up 24 sites or so that's described in this Genetics in Medicine 2005 paper, and that's what this describes. I can't tell you that that's what's going on right now, but that's what they published at the time. So a number of hospitals, clinic settings, even some private MD places, and their particular barriers that they identified had to do with sort of familiarity with this system of doing telemedicine for genetic care. They felt that was a big barrier for them, as well as knowledge about genetic care in general. And we have that problem in all of our genetic interventions. I think most of the people out there don't really know what we do. And we're constantly having to sort of educate them about what is genetic care. The whole process or physicality of doing telemedicine and was felt to be a barrier. People not necessarily being comfortable with cameras and microphones and speakers and that sort of thing. And then credentialing is an interesting issue. You know, for every institution that you may have a connection with, that physician or licensed practitioner has to be credentialed in that institution. So David will probably speak some more to that, as I think you have before, because that's an interesting issue as well. Next slide. By the way, cross-state things require licensure in multiple states, and that's also a potential barrier. So over about 2.5 years or so, they saw 105 patient visits. Most of them were pediatric care. They had a significant connectivity cost. I guess $250 a month isn't that bad, but the internet's free. And so I'm hoping that we will progressively all move towards a more free kind of a system and not have to pay to get in front of the camera to talk to the patient or vice versa. Next slide. The Northwest region. So these are slides that I borrowed from Sylvia Au, and they were part of a presentation that we both gave to the American Telemedicine Association a couple of months ago, basically telling them about genetic care using telemedicine. So she's kindly allowed me to use these slides. This is in Washington State. You can see that they, from Seattle, that would be the University of Washington, send out their, they do telemedicine care in Yakima. So next slide. And at that site, or in that system, they did, over the course of about 3 years, 3.5 years, 27 visits, which were, I mean, 27 is a lot better than nothing, right? But 27 visits in 3 years is not where we'd like to be. And so there are obviously barriers to getting this done, and we've got to sort that out. Next slide. Oregon. Oregon has Portland sending or getting medicine care to 4 different sites. Next slide. And they did, over the course of 3 years or so, 64 visits and 43 scheduled clinics. So they actually had 1.5 patients per clinic visit, which again is, you know, a lot of work of setup and scheduling. If so, there's another issue that we need to sort of deal with. Next slide. Hawaii and the islands there. This is actually where Sylvia Au works, and she's set up a lot of this. So it's you know, Oahu and sending their telemedicine to other number of islands. Next slide. That is, by the way, the characteristic, or the quintessential, I should say, geographic barrier for using telemedicine. I mean, these are patients who won't see a physician with genetic experience in any other way unless they fly to another island. And that's prohibitively expensive. And anyway. So over the course of about 4 years, they had 42 sessions. Now, sessions, I think if I recall, they saw about 5 to 10 patients per session. So they were seeing a whole bunch more patients. I think that has to do with the fact that they have no other choice. And in places like Louisiana, where people think, well, you know, do I want to do telemedicine, do I want to drive, you know, so or not. Places where you have alternatives, I think telemedicine tends to drop down the list in terms of their degree of urgency to do it. Hawaii doesn't have another option. And that's why I think they have a much more successful and bigger program. Next, please. So Bob Zori in Florida with his colleague, his genetic counselor Heather Stalker, have been doing telemedicine from Gainesville to Pensacola, I think Pensacola, in 1 or 2 sites. And they've been doing this for a number of years, basically because they had so many patients that they couldn't see in a timely fashion, that they used it as a sort of a genetic screening mechanism, I think, to figure out which patients do we actually have to see face to face, and which can we handle in a more telemedicine sort of fashion. And they felt that satisfaction on both sides was very high, and that's an ongoing system that seems to be going well. It's paid for by the receiving hospital in Pensacola, who set up the whole deal, and basically they foot the bill for this. I don't think that reimbursement plays a major role in this on either side. Next slide. David's going to tell you about Georgia. Next slide. So in Region 3, can you click it one more time? Actually, one more time again. There we go, that's all. So in Region 3, as we were coming into using this particular cycle, we thought about the possibility, and I'll explain it a little bit more in a moment, of combining the use of telegenetics for regional coordination and care, but also using it in terms of disaster preparedness. And I'm from New Orleans, so I probably don't need to say very much more about that to you. But so we're very interested in the opportunities that this sort of a system allows folks who are in an emergency or not. Next slide. So in the early cycle of this particular grant, we started doing this actually out of Tulane because the software that's being used on one of these machines was being developed actually at Tulane at the time. And so it was available to us, it was free, it was easy, and we were their incubators. So that was great. Within a year, we had Katrina and Rita pay us a visit, and the entire infrastructure network sort of crashed, which was both a problem, but it also raised the opportunity of using this to solve some of those problems. And so we built Telegenetics purposely into the second grant cycle, which we're in right now. So we've been using this system specifically for grant coordination, as I said, collaborative educational sessions such as this, and to try to develop clinical care within the states in the Southeast region. Next slide. So this is a very early incarnation of this particular software, which is internet-based, and you can see Jess Taney and Amy Cunningham, maybe you can see in the back there, and this was at Tulane, and we were talking to a few people here in other states about things related to newborn screening. This wasn't actually care, we were just conferencing. Next slide. This was one of our earlier educational sessions, and that's Larry Sweetman, who was at Tulane at the time, and we sent that out to some regions to talk about early newborn screening. That was in 4 or so, I think. And that, you know, that sort of wetted our whistle for doing this more frequently, and it seemed like a logical and obvious thing to do. Next slide. As I said, Katrina and Rita came along and really messed things up in this part of the Southeast region. Next slide. And so we started to consider how one could use these telecommunication systems to solve some of our problems, acute problems in that region. And this is Bruce Bowdish, who is now at the ACMG and was one of the developers of the early incarnation of this software. And he's actually sitting in my driveway using my wireless in my home at the time when getting a Wi-Fi spot in New Orleans was a really good thing to know. And so I had electricity and a telephone line, so I had Wi-Fi available. And so he's sitting in the car doing basically some telemedicine or telecommunications activities when our offices really weren't available to us yet. That was the office. Next slide. So here's the system. It's a laptop and a camera and a microphone and the internet. And so we thought, well, if the other potential benefit in an emergency is if you have a satellite modem and a power source, you can do this anywhere on the highway while you go into the beach or whatever. And that's very appealing because, you know, when you lose electricity and or internet, there's a possibility for communication when there wouldn't otherwise be any. And so that's a really powerful concept that we haven't fully realized, mostly because the Aston Martin's too expensive. Next slide. But here we are doing actually some telemedicine between my kitchen and Women and Children's in Lafayette, which is 2.5 hours away, and I'm talking to my colleague Scott Davis about an X-ray, and this was a really great way to do that. One of our genetic colleagues landed in Lafayette. He sort of lived there because his home was unavailable to him in New Orleans, and so we could communicate using this system, and it worked very well. Next slide. So I've sort of told you this. This is what our goals were, and then we put this system, basically a laptop and the camera and the microphone, in the hands of people in Louisiana, Florida, Mississippi, South Carolina, Alabama, Virgin Islands, and Puerto Rico, and asked them each to try to set up 2 distant sites within their state that they could set up and have telemedicine interventions with. And it was up to them, whatever worked, whatever they could find. And I'll tell you what we did in Louisiana. Next slide. So in Louisiana, we put one in the NICU at Women and Children's, which is a high-volume nursery that doesn't have genetic care otherwise. We drive up there every 2 weeks for clinics, but otherwise they don't have access to that sort of thing. And we also have one in a residential facility where we have 2 metabolic disease patients. One is a profoundly affected PKU kiddo, and another is a patient with propionic acidemia. And those folks don't have any other support dietary-wise or that sort of thing, how to handle them. We would see these patients in a clinic every 3 to 4 months in Alexandria, and then do a session with the nursing staff after the visit to go over the labs that we saw, to say, do you have any nutritional problems? How's it going? By the way, you know, the glycine level's very high, so maybe we want to cut back on the protein a little bit, those sort of interventions. And so over the course of about, I don't know, 3 or 4 years, we've done about 16 of these, which is, again, a fairly underwhelming number of interventions. But part of that has to do with the fact that the NICU, which was initially very eager to have this system, has vastly underutilized that system because they know we come up every 2 weeks. And so they just wait for us to come up, and they say, well, you know, at the end of your clinic day, would you mind seeing these 2 or 3 patients in the NICU? Which I'm disappointed by, and but it was an interesting lesson. And next slide. So the barriers that I think we have learned about, both locally and from national programs, are that you can't just give people equipment and think that they're going to work it out. You know, there needs to be human effort on both ends, and so you need to somehow provide for that effort. And you know, mostly we don't have money to pay salaries for people on the other side. But there has to be recognition for the fact that everybody's always 100% busy already, and then you're asking them to do something else. And so I have to think about the fact that it's not just the equipment that people need, but also the time, effort, and motivation to do these activities. The technological barrier is not trivial. Some of these systems are much more complicated than others, and the one we have and we're using is probably among the more complicated ones, and that didn't help anything. So Zori in Florida is actually looking at what he calls a Skype box, which is essentially a one-button on-off kind of a system, where you know, nobody needs training to be able to do this. And that will give you maybe less of a payoff, but will probably work in places where other systems won't. Financial is an issue. Setup is getting cheaper. The equipment is much cheaper than it was 10 years ago, but it's the human cost that we haven't been calculating in, and the effort, and I think that's a really important piece of this whole thing. And then availability of folks like me or David who might be doing this. We had been doing this on a sort of an on-demand ad hoc basis. Call me up if you have a consult, and we'll set up a time tomorrow and we'll do the consult. That doesn't seem to work as well as having actually fixed hours every week or 2 weeks or whatever to say, here's my telemedicine window, here's when you can connect with me, call and schedule a patient within that time. So I think that that's another important lesson. Next slide. So this is another way of rationalizing our lack of incredible success, I think, and that has to do with the fact that as we think about healthcare in general, common things and familiar things tend to get more attention, like diabetes and hypertension, and we in genetics are more along the decreasing end of the spectrum there of increasing complexity and decreasing frequency and familiarity to other people. And then we want to add telemedicine onto the end of that, and I think that's where we start to get sort of a dry faucet in a sense. And so I don't know how to fix this problem, but we obviously still need to work actively down at that end of it. Next slide. We have been very successful in also doing teleconferencing, and you guys, better than most here at Emory, probably know about this lovely library of lectures, which have been taken partly through these sessions, partly at other conferences and put up, and they can be streamed discontinuously now by anybody, and you can see the slide set and learn what was being taught at that lecture, and look forward to having this session up on that session board as well. So that's a great resource. Next slide. So in summary, I think telemedicine can work very well for what we're doing, but at least in my hands, in our experience, we still have a number of things to tweak and to deal with. It's vastly underutilized still in all the regions. If you look at those numbers of patients being seen, most physicians are seeing 500 to 1,500 patients a year, and if you're seeing 40 to 60 over 2 or 3 years, obviously we could probably be doing more of that. And then, I think smartphones and tablet technology and all that sort of stuff, which many of our patients are going to have at home anyway now, may allow us to do some of this stuff in a much more informal manner than having to go to a clinic necessarily and sitting in a room that's all set up with a facilitator. So those are all great opportunities.